Good morning, everyone, and welcome to today's TIRO by MD's webinar. I am Dr. Camilo Gonzalez Velasquez, and it's my pleasure to host today's session. We're honored to welcome Dr. Louise Davies, Professor of Otolaryngology, Head and Neck Surgery at the Geisel School of Medicine at Dartmouth, and Senior Faculty of the VA Outcomes Group. Dr. Davies is internationally recognized for her work on cancer epidemiology, overdiagnosis, and patient-centered research in thyroid cancer. Her efforts have reshaped how we think about diagnosis, monitoring, and shared decision-making in thyroid disease. Joining her is Dr. David Oliver Francis, Professor and Vice Chair of the Otolaryngology, Head and Neck Surgery at the University of Wisconsin-Madison. As an NIH-funded surgeon scientist, Dr. Francis leads the PATCAM microsimulation model focused on overdiagnosis and survivorship in thyroid cancer, and is a national leader in the health services and research and surgical outcomes. Today, they will be presenting together their group's recent publication, Differential Ultrasound Rates Mirror Sex Disparities in Thyroid Cancer. This study explores how gender differences in diagnostic and imaging may contribute to observed disparities in thyroid cancer incidence. Joining us as our expert discussant, Dr. Maaike Van Gerwen, Director of Research in the Department of Otolaryngology at Mount Sinai and Scientific Director of the Program for Personalized Management of Thyroid Disease. Her research bridges clinical, epidemiologic, and environmental factors in thyroid cancer, and we're thrilled to have her insight today. Before we begin, I'd like to go through some announcements. First, I'd like to invite all of you to send any questions that you might have for the presenters through the platform's Q&A function, and we'll try to get as many of them before the end of the hour. Secondly, I'd like to invite you all to tune in and listen to the podcast series that we have put together. TIRO Voices of Wisdom is a podcast intended for thyroid specialists and trainees that has pearls in the diagnosis and treatment of thyroid cancer, hosted by Dr. Dana Hartle and funded by Dr. Janice Pasieka, and hosting a lot of international leaders in the field. Additionally, I'd like to invite you to register and attend the World Congress of Thyroid Cancer in Boston, Massachusetts, coming up in a couple of weeks. Hopefully, we'll get to see many familiar faces there. And now, with no further ado, Dr. Davies, Dr. Francis, the floor is yours.
So thanks again for having us. We thought we would start out with just a little bit of background and then go into sort of the meat of the paper itself that we're here to discuss. And if we can advance the slide to the next one. These are our disclosures. We don't have any commercial disclosures. The work has been funded generously by the NIH and the Department of Veterans Affairs. Next slide. So I think this paper is helpful to start with, to show some background. This is a figure from a paper that we wrote together a few years ago. And what we're seeing here on this graphic is the difference in incidence of thyroid cancer over time between men and women. Now, for this paper, we analyzed SEER data, which, if you're not familiar with SEER, it's the nation's source of population-based data on what's happening in the war on cancer. Incidentally, it was started by the Republican president, Richard Nixon, has now been around almost 50 years, though, since the 1970s. And SEER is really how we all know what's happening in the United States in terms of incidence and mortality of cancer. And so let me walk you through what you're seeing here. So we have years along the bottom axis, and then on the y-axis vertically there, we have the incidence rate per 100,000 of thyroid cancer. And the dotted lines here are women. You can see that incidence rates are much higher in women. And then the parallel orange line is the contribution of papillary thyroid cancer. You can see that the incidence rates have been going up dramatically over time, and that the parallelness of the lines there that you see, especially in women, means that the major contribution comes from the increasing incidence of papillary thyroid cancer. Now you can see the men on the solid lines, they have a very similar pattern. Their incidence rate has also actually been going up quite a bit, but it's just been so much more in women, it's much more dramatic. And in fact, the incidence of thyroid cancer is about 4 times higher in women than men. The mortality rate, however, is the same between the two. Mortality is a measure of how many people in a population actually die from the cancer. And it, unfortunately, despite us picking up more cancer, we've not done anything to improve our mortality rate. And two things are especially important. There is this rising incidence, but unchanging mortality. And that actually suggests that we're finding a lot more mild disease. And the second thing is that there's a huge difference in incidence between men and women. And I'm going to explain number one briefly, because you need to understand it so that we can discuss number two, which is the huge incidence difference between men and women. And that's what we're going to actually spend most of the day on as Dr. Francis gets started. But this increasing incidence with unchanging mortality, this is a phenomenon we call overdiagnosis. It means detecting a disease that is quite mild, like in fact, so mild that people don't even know they have it. We call that having a subclinical reservoir. And it means that if you never found those people with those cancers, thyroid cancer is one, but prostate cancer is also a disease that has a subclinical reservoir. People might never have actually needed treatment at all. And this figure shows that clearly. You know, thyroid cancer is a disease that has a subclinical reservoir. We have lots of mild disease, and finding it and treating it doesn't actually make fewer people die of the cancer. So let's go to the next slide. This is another figure from that same paper, and we did a meta-analysis of autopsy prevalence of subclinical papillary thyroid cancer by sex. So what that means is you're putting together studies of autopsy specimens, so people who died of causes other than thyroid cancer, but you look at their thyroid glands, and you can see that actually a lot of them have papillary thyroid cancers that they never knew were there. So we examined this by sex, and we found that when you look at these differences, the subclinical reservoir of thyroid cancer does not differ by sex. You would think that maybe it would have, because that might be why the incidence is so different between men and women, like we just looked at on the last slide. But that's not the case. It turns out that the subclinical reservoir is the same in men and women. The difference is 3%, but the confidence intervals are broadly overlapping. So the average proportion of women in the population who have a latent papillary thyroid cancer is 14%, and in men it's 11%. The confidence intervals for women is 8 to 20, and for men it's 5 to 18. Let's go to the next slide. The reservoir also does not differ by age. So this was a similar analysis that we undertook with our group. And what you see down here along the x-axis is age groups of autopsy prevalence of papillary thyroid cancer, and then the proportional prevalence of the thyroid cancer among autopsy specimens on the y-axis. And you can see that the proportion is largely similar by age. So there's not more among older people than there is among younger people. And then last, let's go on to the last slide. This is really interesting. And this is the last figure from that paper. And what we show is that as the lethality of the cancer increases, the differences in incidence rate by sex diminish. Let me walk you through this to understand it a little bit. So what we have again here is the incidence years across the bottom. So we're tracking over time what's been happening. And then the incidence rate ratio, which means the ratio among women compared to men of the incidence of that particular cancer. So what we find here is that papillary thyroid cancers that are 2 centimeters or less, the ones that are most commonly found at autopsy, the incidence rate in women compared to men is 4 times greater. But as you get to more lethal kinds of cancer, so other like larger papillary cancers, and then you go on to follicular and Hürthle cell, medullary, and then anaplastic, the ratio of the incidence gets to be much closer to 1 to 1. So these cancers that are much more likely to present with symptoms, that are likely to become much more clinically obvious, the ratio gets much closer to 1. So this pattern suggests that something is happening that is making us find those subclinical cancers. Let's go to the next slide. And you can think about a few different potential reasons for this. Is it the biology of the cancer? Is the biology of the cancer actually different between men and women, despite what we're seeing on those prior slides? Is it about patient preferences for care and care seeking, or healthcare utilization patterns, which is pretty close? Is it about physicians and other practitioners driving what happens in healthcare? It's hard to know exactly. So we've been doing work together to dig into these systems over the past several years. And one result is the paper that we're going to share today. And if you can go to the next slide. In this paper, we take on healthcare utilization as a potential contributor to the difference in incidence in thyroid cancer between women and men. Ultrasound is the most upstream event in the path to diagnosis of thyroid cancer, and ultrasounds get ordered for lots of reasons that are listed here on the left side. But commonly, like sometimes people have a symptom, but actually they have no mass that you can palpate, or they might have throat fullness or tightness or a globus sensation, or sometimes they have a mass but no symptoms. Like many of you know that people can have pretty large goiters actually and not have many symptoms. But people get referred to ultrasound for lots of reasons. And what I'd like to do now is turn the floor over to Dr. Francis, because he's going to walk us through what we discovered in this paper. Now that you sort of have a little bit of background to understand, like, why do we care about this and why should we care? Because actually, I think it's pretty important.
Thanks, Louise. So next slide, please. So in general, what we're talking about today is trying to understand better a little bit how utilization and sex disparities may relate to each other. As Louise mentioned, there's about a 4-to-1 incidence ratio between women and men for small papillary thyroid cancers. We really don't have an adequate explanation of the large sex differences. There's been a lot of hypotheses about what could potentially explain them. Is it biology? Is it autoimmune disease differences between men and women? But we really don't have a good explanation. There's a lot of hand waving and ideas out there, but the research really hasn't borne out yet. So sex disparities in thyroid cancer incidence has been understudied in the context of diagnostic testing patterns, and that's what we really wanted to go after. So one of the questions we wanted to ask is, can we identify how imaging and testing have contributed to the increased incidence of thyroid cancer over the last 25 years? Next slide, please. So our primary hypotheses for this project were that the rate of fine needle aspiration biopsy per ultrasound would remain relatively stable over time and would not differ between men and women. And the second hypothesis was that the differential use of diagnostic imaging over time is associated with a large sex difference in thyroid cancer incidence. Next slide, please. So just a little background. The data we're going to be talking about comes from Kaiser Permanente of Washington. This is a map of Washington state, which includes both Seattle and Spokane, which are the stars there you can see. Those are quite populous areas in the state. But it also includes some very rural areas like Yakima and Whatcom counties. So it provides a nice overview of kind of different geographic areas within a state. And next slide. So the first analysis we did was to compare thyroid cancer incidence in Kaiser Permanente, Washington, both to the SEER trends in Puget Sound. Puget Sound is one of the SEER sites that provides data to the National SEER Registry. And we also compared Kaiser Permanente data to national SEER incidence. And all three were virtually identical, which was an unexpected boon for the project. We defined our Kaiser analytic cohort as all adults between 1997 and 2019 who underwent a thyroid ultrasound. For that cohort of about 55,000 people, we had utilization, sociodemographic, insurance, and comorbidity data. And for the 800 to 900 people who were diagnosed with cancer, we had all the tumor registry data. We also requested, importantly, covered lives denominator file. What does that mean? So in order to make rates, we need to know the denominator. And so we requested all the patients who are covered by Kaiser Permanente Washington for every year to calculate these rates. Next slide. So our first analyses were to describe the time trends in ultrasounds, biopsies, and cancer incidence. And I think we found some really interesting trends regarding the role of sex in thyroid cancer diagnostics. We then were interested in whether these effects persisted in multivariate setting, and we used Poisson regression models with an offset for that purpose. Next slide. So sociodemographic characteristics of patients who received ultrasound are summarized here in this table. These are shown as annual mean proportions, which reflects how these data were treated in our models. There were over 33,000 patients of about 7 million covered lives in Kaiser Permanente who underwent 39,000 thyroid ultrasounds from 1997 to 2019. The number of covered individuals grew over time from about 235,000 to 311,000 between these periods. And about 900 received a diagnosis of thyroid cancer. As you can see from the table, it's not surprising. The majority of patients in all age groups were middle-aged and women. 70% received an ultrasound who were white, and 75% had in-network coverage. That means they were cared for within Kaiser and not outside of Kaiser. And 25% received care from another health network associated that was outside of Kaiser. Next slide. This table goes over kind of some generalized rates. Ultrasound rates were high. It was 587 per 100,000 individuals in Kaiser Permanente. And cancers were relatively uncommon, and the majority were the least lethal papillary thyroid cancers. And more concerning types and more lethal types were less common. Although we did not present summaries here by sex, women underwent ultrasound about 3 times the rate of men and had fine needle biopsies about 3 times the rate of men and had 2.4 times the thyroid cancer incidence. Next slide. So just to make it very simple, I like to think about things super simply because it helps my brain. And so I just want to kind of lay out some of these ratios we're going to be talking about. The first is annual ultrasound rates by sex. And so what this is patients who underwent a thyroid ultrasound over all the patients they're covered by Kaiser Permanente, and that's per 100,000 individuals. Next slide. Shown here are the health system thyroid ultrasound rates over time by sex. The red line represents females and the green line represents males. Along the y-axis are the years, and the x-axis are thyroid ultrasounds per 100,000 people. You can see the ultrasound rates increasing over time pretty dramatically over this period. And the base rates for thyroid ultrasound were both higher among women and increased more quickly over time. Next slide. And just to kind of put things in perspective, it's always helpful to kind of check yourself when you're doing these kind of things. And we compared it to Dr. Haymart's study looking at Medicare data, obviously an older group. Our study looked more at kind of privately insured working-aged individuals versus older folks who were included in Medicare. And the pattern that we're seeing is similar to what she and her team found in the Medicare data, which bolsters kind of the face validity of what we're seeing. Next slide. So the next thing I want to go over are biopsy rates and biopsy yield per year over this period of time. On the left is going to be the thyroid biopsy rate for the health system over time. And next slide. There is a large sex difference. The biopsy rate increased through the early 2000s before stabilizing and dipping. On the right-hand side, we show what is basically the test yield, that is the biopsy rates per ultrasound. Next slide. Despite increasing ultrasound rates, the biopsy yield from those ultrasounds has stayed relatively stable over time, and the sex disparity shown at the population level is conspicuously absent. In fact, you'll see that actually men and males had a higher biopsy yield than females, which reverses kind of the way we think about things. The tumor yield per biopsy has been relatively stable over the last 15 years, also without much difference between sexes. So we thought this was pretty interesting because it suggests that sex differences in thyroid cancer might result from differential imaging rates, not from underlying incidence. And we've worked to extend these findings to the multivariate setting. Next slide. The next thing I want to go over are thyroid cancers and biopsy yields. So on the left, we trend cancer diagnoses across all patients in the health system from 1997 to 2019. Next slide. It shows that thyroid cancer incidence has increased and then stabilized in the mid-2000s, followed by a decline. On the right side, we show the biopsy yield. That is the number of cancers identified per biopsy. Advanced slide. We found that cancer yield per biopsy has been relatively stable over the last 15 years, also without much differences between sexes. We thought this was interesting because it suggests that we have not gotten any better at finding cancers or choosing which nodules to biopsies. Next slide. So to recap these findings, we found that the rate of thyroid ultrasound was higher among women at baseline and increased more rapidly than among men. We found that rates of biopsy and thyroid cancers were higher among women than men across all years. However, when we look at the ultrasound yield, the proportion of ultrasounds resulting in biopsy, the sex difference disappeared. That is, women and men who underwent ultrasound had similar likelihoods of undergoing biopsy. When we evaluated biopsy yield, the proportion of biopsies that resulted in cancer diagnosis, the sex difference again disappeared. In other words, men and women who underwent biopsies had similar likelihoods of being diagnosed with thyroid cancer. Taken together, these data suggest there's not a difference in underlying prevalence of thyroid cancer between men and women. Next slide. So this table summarized the results of our Poisson regression with offset. Adjusting for in-network status, race, and age, the effect of sex on biopsy does persist. Men are significantly more likely to undergo biopsy with about 1.06 times more biopsies than women. High comorbidity burden and a larger proportion of patients aged 50 to 64 are also associated with greater biopsy rates. Age 18 to 34 and the proportion out of network were negatively associated with biopsy rate, and year was also negatively associated with biopsy rates, which may indicate that we're getting more choosy about which patients to send for biopsy. Next slide. Our findings indicate that the extreme difference in thyroid ultrasound rates between men and women is likely leading to greater detection of disease in women. So the sex difference in thyroid cancer is largely explained by differential rates of thyroid ultrasound. Advance. And importantly, sex differences disappeared after diagnostic ultrasound. The biopsies following ultrasound were higher in men, and cancer diagnoses following biopsies were no different between sexes. Next slide. So there's some limitations to our study. First, this is data pulled from a single managed care system in the Pacific Northwest of the United States. It's an observational study, so there's standard things that we worry about with any observational study. And although we looked back 18 months to make sure there was no previous thyroid cancer, an individual could have had a diagnosis before that. And of course, there's concerns, as always, about sample size, especially tumor counts, which were variable by year. Next slide. So why do women undergo so many more ultrasounds than men? That's really the question that we're trying to get at. And I think it's an interesting one that needs to be explored because this may underlie some of these massive differences we're seeing between sexes for thyroid cancer. And it gets back to this Venn diagram that Dr. Davies showed earlier. When we're talking about this, is it biology? Is it utilization? Is it provider practice patterns, patient preferences? Is it something in the environment? And next slide. I mean, based on the data we're seeing, the sex differences seem more related to how providers are behaving and how we're using and how healthcare utilization is happening. Women use healthcare about two, and especially in middle age, about two times as much as men. And so they're more exposed. And then also the way providers work with men versus women may differ, and we don't really have great data on that, but that's something that needs to be explored. Next slide. So some takeaways from this study are that differential thyroid ultrasound rates seem to be a primary driver of sex disparity in thyroid cancer. And contributors to differential rates relate to differential healthcare utilization by sexes and potentially differential clinical decision makings around ultrasound. And while we've done a fairly good job of developing guidelines for many things in our field, there are no guidelines that exist of when to order a diagnostic ultrasound. Next slide. So getting back to this issue of healthcare utilization, advance, please. It gets back to kind of thinking through the pathway to diagnosis. And this is something that our team's very interested in, is looking backwards. Most of the time when we're talking about cancer, we're talking about screening or ultrasounds going forward, but so much happens before the ultrasound. Why are we referring patients? What's the clinical decision making? What are the indications that should send us to ultrasound? And this really, I mean, is a very rich area for research and needs to be explored a little bit more. Because the upstream effects are affecting the rates in the incidence that we're seeing. Next slide. So as a little aside, the reason we did this study in the first place is because we needed data for this large model we're developing. The model has now been developed. We developed a model of thyroid cancer epidemiology in the United States using microsimulation approach. And this is a very powerful tool. It requires a lot of high quality data from around the country and around the world, in fact, that we were able to put together. And I'll explain a little bit about why we did this. Next slide. So the papillary thyroid carcinoma microsimulation model, or PATCAM, is a discrete event microsimulation model that uses systems engineering approaches to replicate thyroid cancer epidemiology in the US over time. So this model basically allows us to ask difficult questions about screening, overdiagnosis, what if we change policy which are hard to do in a clinical trial. We can do them using this mathematical approach. Next slide. So it's the first simulation model to reproduce observed US thyroid cancer incidence and mortality using sex and age-specific differences in thyroid cancer trends. And it's poised to address some problems that are difficult to answer with clinical trials or conventional statistical models, such as rates of overdiagnosis by sex and age. What if the impact of incidental imaging on thyroid cancer incidence, the effect of changing biopsy thresholds, and outcomes of active surveillance? We can actually follow patients and look at what would we do if we didn't treat them? What if we treat them with this treatment versus that treatment? What if we change the biopsy threshold? What would happen to outcomes for thyroid cancers across the entire United States? And so it's really a resource for simulating population impact of policy and guideline decisions. Next slide. And as we were building the model, we had a massive group of experts from around the world who helped us with kind of thinking through model inputs. And I'm not going to go through all of the people's names here, but suffice to say that we tried to make sure we had patients and policymakers as well as all the groups that would be involved in caring for this for the thyroid cancer patients. Next slide. And just briefly, I'm going to go through slowly here kind of what this is. So as microsimulation model means that for every single we modeled for every single person in the whole United States, the risks of getting thyroid cancer, and then grew them over time. So we started this model in 1920, and we basically grew thyroid cancers from 1920 to 1975. And for every year, we went through the simulation for each patient in the United States, or each person in the United States. So inputs the person, and we first asked, did they have a non-PTC death? Forward, please. If they did, then they're out of the model. Next. Then we put them through a natural history component. This means we grew their cancer. Next. And then if it was detected, then they went into a detection component to the model. Next. If it was detected, then yes, then they went to a post-diagnosis component, and next. And then they were outputted. So that's kind of like what would happen after the cancer's been identified. Next. If they weren't detected, then we incremented their age by 1 year. Next. And then we asked, is the age greater than 110? Because if they're 110, we're probably not going to be alive anymore. And then next. And then we put them through this. So every year for every person in the whole United States, we basically grew cancers, using this model. And it's way more complicated than this and required some really massive amounts of data and computing power. But basically, this allows us to grow cancers over time for the whole US population. Next slide. And one more. And this is how we did compared to SEER. So our model was the red line here, and SEER is the black line. And on the left is women, and the right is men. And the y-axes are the incidence per 100,000 individuals, and the x-axis is years from 1976 to the present. And we actually projected forward, which I shouldn't have shown, but it's here. And the two other lines are palpable and non-palpable cancers, and we were looking at indications. But the most important thing is to see the fit. So basically, we could fit SEER data almost perfectly over this period of time, as much data as we have using this model, which implies that the calibration that we did was pretty accurate. And then we compared this model also to some active surveillance trials to see how our natural history component worked. Those are data from Memorial Sloan Kettering, Kuma, Cedars-Sinai, et cetera. And we could grow the cancers the same rate that they did using their data. So we feel pretty confident we have a good model that can be used to look at these complex things. And we're excited about next steps for that. Next slide. So in summary, with PATCAM, which was the reason that we pulled these data in the first place, PATCAM is a tool to investigate policy change impacts on thyroid cancer epidemiology across the cancer continuum. So that's kind of what we wanted to show today. And then, of course, this does not happen in a vacuum. There's a massive group of people who are involved in doing this, including biostatisticians, engineers, modeling folks, and then obviously our collaborators at Kuma, Kaiser, Kaiser Permanente in Washington. And this is the group that basically put this all together. And I think that's all we have today. Next slide. Thank you for your time, and I look forward to discussion and questions.
Thank you, Dr. Francis. Thank you, Dr. Davies, and congratulations on your work. We're gonna just jump to Dr. Van Gerwen's discussion, and then we'll come back for a little bit of Q&A.
So congratulations, Dr. Francis and Dr. Davies, for this really nice paper. And thanks for the opportunity to discuss this paper and talk a little bit more about background. So talking again about sex disparities in thyroid cancer. First of all, I have no conflicts of interest to disclose. I just highlight here the funding that we received for the research that we've done so far. And looking at the presentation that Dr. Francis and Dr. Davies just did, there's some overlap because I wanted to also go through some of the impressive work that this group already did on this topic. So as Dr. Davies already mentioned, the work that they did using the SEER data, which I think served as the basis for the work that they just presented, the recent paper that they did, where you can really see that thyroid cancer, and then mainly papillary thyroid cancer, exponentially increased in women. It increased in men as well, but at a little slower rate. And when they looked at the incidence ratio for the smaller, the below 2 centimeter papillary thyroid cancers, at the end of the graph, there was a male to female ratio of 1 to almost 4.5, while the mortality ratio was almost equal 1 to 1 between those two groups. And then looking at the histologies, again, the below 2 centimeter papillary thyroid cancer, when they looked at the beginning of the graph, it was a male-female ratio about 1 to 3.5, and did increase for this group to 1 to 4.4. So there's an increase, especially in this less aggressive, smaller type of thyroid cancer, while the male to female ratios for the other, the larger papillaries and the more aggressive histologies remain stable or slightly decreased over time. Then also already highlighted is this study that looked and pooled the autopsy studies of 12 different study populations together, resulting in a combined population of a little over 2,300 patients, 877 females and 1,425 males. And there, the prevalence of subclinical papillary thyroid cancer was almost equal, right? So we have about 11% in males and about 14% in females, which resulted in a p-value of 0.5. So there was no significant difference when looking at this in autopsy studies. And this study was also already highlighted. So 16 pooled studies looked at the different age groups, and where we usually expect an increase in thyroid cancer diagnosis, so around 50, so in this age group of 41 to 60, they did not find that here. So here, if you look at the different age groups, the confidence intervals overlap, so there was no difference in prevalence of subclinical PTC. And the prevalence did not differ across the lifespan for males and females. So for males, it was between 11 and 13%, while for females was around 10.8 to 13.9%. So now going to the current study that they did, just following up, looking at, okay, why is there this difference? They did this retrospective cohort study with 33,589 patients, and of which 78% were females. And they found that that females underwent about 3 times more ultrasounds than males. So they increased more over time, although males also increased in thyroid ultrasound rates over time. Then the biopsy rate also went up, and females underwent 3 times more FNAs compared to males. And then lastly, the cancer incidence, we talked about a little bit more already, was higher, about 2.4 times higher in females compared to males. And I want to talk a little bit more about the proportions that they looked at, right? So looking at the proportions of ultrasound resulting in biopsy, that decreased over time. As you can see here on the right side, both for males and females, there was a decreasing trend. However, throughout most of the time period, the proportion of ultrasound resulting in biopsies was higher for males compared to females, which is quite an interesting find. And then the rate of FNAs leading to a thyroid cancer diagnosis, there's really no difference. So the graphs completely overlap between males and females. So the conclusion was, is there the different rates in diagnostic ultrasound explain in part the sex difference found in thyroid cancer rather than a higher underlying rate of thyroid cancer for females, and that males underwent FNAs at higher rates. And they brought up a couple of interesting potential explanations for this find. Physicians that test overall at higher rates have a higher patient panel with higher thyroid cancer rates. So testing leads to finding it more frequently. Also, in their discussion, they mentioned that a third of the physicians order ultrasounds without a clear indication. So as they already mentioned, there's a lot of different reasons to order an ultrasound. And it seems to be that a better and clearer explanation and guidelines to when to order ultrasounds is needed to potentially not have people undergo ultrasounds where it's not needed. We definitely know that females seek more care. Women, especially in reproductive age, see a doctor more frequently and are potentially at risk of having certain diagnostics done that potentially leads to finding something that would have not led to symptoms otherwise. Females have also a higher rate of thyroid disease. It's well known that autoimmune thyroid diseases are more prevalent in females compared to males. And that leads to seeing a doctor more frequently, having ultrasounds done more frequently, and potentially also finding a nodule more frequently. However, does this explain everything? That's the question. There might be other contributing factors to this sex difference in thyroid cancer. Thyroid cancer is the only non-reproductive cancer with a free female predominance. And can this be explained only by them having more ultrasounds? I want to highlight this figure that was published in Thyroid in 2022 by Dr. Sobab and her group that looked a little bit more closely at potentially other factors of this sex difference found in thyroid cancer. I'll walk you through the graph. So this sex disparity in thyroid cancer increases from childhood through adolescence all the way up to menopause. And we see that this gap disappears after menopause, so that there are some hypotheses that say that there might be a hormonal difference. The hormonal difference of males and females plays a role in the gap between males and females having more thyroid cancer. It is well known that that estrogen has a proliferative effect of both the innate and adaptive immune system, and testosterone has generally a immunosuppressive activity. So that's highlighted here on the left side of the graph, where there is a difference between males and females that potentially interacts with the thyroid and having this impact of getting more cancers in females. Another difference is that there females have an extra X chromosome, and X chromosome inactivation has been implicated as a mechanism underlying the higher propensity of women developing autoimmune thyroid disease. And we know that autoimmune thyroid disease has been linked to a higher thyroid cancer incidence rates. So that may be a reason, an additional reason why we see more thyroid cancer in females. Also, there is a different exposure pattern in males compared to females, which may be an additional reason why we see this difference between males and females. So we can think about, for instance, people working in agriculture that are exposed to pesticides and are actively applying pesticides have a higher exposure, and these are mainly males. Could that be a reason for them to have a potentially more aggressive type of thyroid cancer, which is found? We also find higher rates of thyroid cancer in military who have a specific profile of exposures as well. So could that be a reason to think that that potentially accelerates thyroid tumor growth and having them diagnosed with thyroid cancer? So there's still a lot to uncover. Most of this we still have to learn a lot about. There is definitely this difference, and I think looking at all these different impacts together, including seeking care and having ultrasounds done, is an important field of study in the near future. Thank you again for this opportunity to discuss this paper, and I'm happy to take any questions.
Thank you, Dr. Van Gerwen, for your excellent discussion. And thank you, Dr. Davies and Dr. Francis, again, for presenting today, carving out some time to be here with us. And while we take some questions from the audience, I'm going to go ahead and ask some questions of my own. And two things that I've wondered or have been thinking about is the very first time, actually, that I heard that paradigm that the female gender had more thyroid cancer prevalence and incidence, and that was broken. That idea was broken for the first time by your group, actually, when we started reading the outcomes from autopsies and seeing how that was not very different. Looking at the graphs that you showed, where as the more aggressive or the bigger the nodule gets or the thyroid cancer gets, the disparity closes. I always look at the graphs and there's a clear cut that the graphs stop at 2019. And I wonder if you saw any changes happen in 2020 where the diagnosis, the way we treated, the way we screened people had a severe difference on what normal life was. The pandemic had us shut down the healthcare system for many reasons. Did it change in that year in any way?
Yeah, we actually did look at the data in 2020. I wasn't totally prepared for this question, but we did see a change, and we saw that there was a deficit in case detection, meaning there were what we would call missed cases, and there were many missed cases that were small cancers, small papillary thyroid cancers. So those cases may or may not ever come to attention. But interestingly, we also saw that there were what we would call missed cases among some of the most severe types of cancer, including anaplastic thyroid cancer and medullary. And based on the other analyses that we've been doing, looking at the health outcomes that occurred during the pandemic in cancer care, which is part of a separate grant that we have, we suspect that there were a few things at play. One is definitely a change in healthcare utilization, but also another concept that we call harvesting, which is sort of a not very nice, a sort of a gauche way of saying forward displacement of mortality, meaning people are dying of other causes, and so they're not available actually to be diagnosed with and or die of their other cancer. So, so for instance, some people with perhaps an anaplastic thyroid cancer either didn't seek care, or their symptoms were misinterpreted, or they died of, for instance, a heart attack that was brought on by the stresses on their physiology of having a cancer. And so their death gets recorded as something else, not their cancer during the pandemic because of changes in that. Now, they might have died of COVID, but they might have also died of other causes, because people with cancer have an altered physiology. They are more likely to die of other causes simply by the fact that they also have cancer. So it's a little complicated, but I guess the short answer is yes, there definitely were changes. We saw many fewer small papillary thyroid cancers diagnosed, but we also saw some changes that really probably just reflect the stresses on individuals and on the healthcare system and the population.
And just as a quick follow-up question, the ones that we missed, were there differences or disparities in the genders?
We did not look into that. That paper really wasn't about that, and the numbers are pretty small. But we have more data now. You know, the 2022 data are now available, so we'll be able to take that question on as we accumulate. The other thing that we learned from, or are learning from, our pandemic era analyses is that the pandemic wasn't just 2020, that the changes in the healthcare system and healthcare utilization persisted all the way through well into 2023, at least for some of the larger cancers that we've been looking at, like lung cancer screening and lung cancer incidence. So I think we'll continue to see those, and we'll probably need to track those data going forward.
And I would just add one thing, that we did see a differential healthcare utilization drop more for women than men during the pandemic, which was interesting to see. So women didn't use healthcare as much, and rates, and this again is still being kind of worked through, but the rates really were slightly different between men and women during that period of time, but that data is still being analyzed. But there was differential healthcare utilization drops between the two, and men didn't drop as much as women did.
Wow, that is really interesting. And then after that question, where I see the graphs ending in 2019, I'll always go back, and I'm gonna reference something that you both referenced in your presentation. Dr. Van Gerwen went back to that Fernandez-Taylor paper where we have the graphs of the yields and the use of ultrasound, the ultrasounds that ended in a biopsy and the biopsies that ended in a cancer. And when we see the proportion of ultrasound resulting in biopsy, we see how that different closes, and we see a drastic drop in 2010, 2019. And it kind of shows how we were educated by the ACR and by the AT and how to use ultrasound. Then we look at how many of those biopsies ended in cancer, and that kind of shows a different aspect of the evaluation of a thyroid nodule, because one kind of speaks to the ultrasound risk of malignancy, and the other one is the cytologic part of it. So one looks like it was very sharpened, and the other one not so much. Do you have any thoughts about that?
I mean, there's different ways of looking at this problem, to answer this question. I mean, I think, we have guidelines that we've developed over time that may have impacted things some. I think we may have gotten a little better at choosing which nodules to biopsy. I think that is probably that seems like it may have happened, but from biopsy to cancer, I'm not sure we're much better at that. And I think that's an opportunity for us. I think our diagnostics, we know who to biopsy maybe a little better, but we don't know. But the follow through on the biopsy to cancer isn't as good as we probably could be. So I think there's room for growth in terms of improving our diagnostics. In particular, looking at biopsy thresholds, And then thinking about cytology and predictive modeling on that side of things is an opportunity, I think. And it's not something I mean, we all talk about this a lot, but it's not, how do you do that is the tricky bit. And so we're hoping to use some of our modeling techniques that we have in our, to actually explore some of those, trying to change some thresholds to see if that might help make it a better test.
Beautiful. Thank you. And with that in mind, my mind comes back to that Venn diagram where we try to hypothesize or try to think about what is it that it's changing the trends in how we diagnose thyroid cancer. Dr. Van Gerwen was speaking about exposure, and I'm sorry for putting you on the spot, but I am not American. The way that medicine's practiced here, just the healthcare service, the insurance availability, it's very different how it's practiced. So I'm gonna move away a little bit from the exposure and let's speak about who does the ultrasounds. So that I know this is not in the scope of your research, but have you seen, or do you ponder there's any difference between those ultrasounds that are done in an academic center versus the community? Because we know that many of the ultrasounds, as you both have mentioned in your presentations, many of those don't have a real clear indication of why they should have been done. And that's kind of my world. Um, but do you think that there's an impact on who did it, who ordered it, and ultimately how many years they have in practice? Because it seems like now things are changing and the new trainees are being born to this field with new information, like the things that you have published. But people that were trained prior to the 2015 guidelines potentially are doing things the old-fashioned way. Do you have any thoughts?
I'll be curious on Louise and Maaike's thoughts on this. My feeling is that there has been a huge change over time. If you go back to the 80s, basically all the ultrasounds were done mostly. I'm not all, because I'm sure there's people on here that were doing ultrasounds on their own before that, but mostly were done by radiologists. And that's changed significantly since a point of care ultrasounds and so forth. And because of the availability of ultrasound and its quote unquote low risk, people the threshold for doing an ultrasound is really low. And we don't really have any rules around it. And so when someone comes in, depending on how they were trained and their kind of practice patterns, they may immediately think if someone's hoarse or has swallowing problems, that yeah, maybe it's the thyroid, because that's what they think of when that's that quick thinking kind of approach, that they just make that association quickly. We all have these ways of thinking about things in clinic, and especially if you have an ultrasound and you take care of thyroids, I mean, that's the first thing you're going to think about is, could it be the thyroid gland? And so I think there's a lot of work to be done on education around that. And I think that's why this work and some work by some others that are working in the ultrasound space here has a potential to be very impactful for helping us be more efficient with our healthcare utilization. But Louise has thoughts, I'm sure.
Well, well, and actually, I think this gets to, there's a good question from the audience where they wondered whether we had checked which physicians were sending people for ultrasound, whether it was the endocrinologists or GPs, otolaryngologists, and whether everybody sends more women for ultrasound. I can't remember the ins and outs of the data. Maybe you can comment on it, but I do remember in our advisory group, Jonathan Irish made the comment. He's like, you know, when we first started doing ultrasounds, he's like, we biopsied everything, right? Because we didn't know. And he said, you know, we're just much choosier now. But I do think there has been definitely a learning curve in the field. So even as more people are doing ultrasound, I do think people are becoming more savvy, but it's just going to take time. But David, do you remember, like, do we have the data on which specialty was referring for ultrasound in the KPWA?
Yeah, we're still analyzing data. We're doing network analysis to see kind of what are the patterns that we're seeing among providers in terms of how closely they're related to, how closely they refer to radiologists. what they do for what their specialty is, et cetera. And so that's still being run, but it's a great question, and I think that there's definitely something there. We have seen that advanced practice practitioners tend to have certain ones tend to refer more and for different indications. And so I do think there's some education practice pattern situation here that's at play also that we really hasn't been explored enough. And I think that's something we're very interested in. Great. It's a really important question, though.
Well, we've come a little bit over the hour, and I want to take some time to really thank you for carving out some time this Friday morning. It was a lot of fun. I want to invite you all to come back in a couple of weeks because we have a couple of bye weeks with the US holiday and the WCTC coming up, but we'll come back mid-July for association between growth features and coexistence of BRAF V600E analysis. So thank you all for being here. Thanks to the audience for being here, and have a wonderful weekend.